Perfect.
You could go on to the slideshow, please.
Yeah. Excellent. Okay, sun's just come up in Birmingham, so thank you for having me. My name's Sally and I'm a dietitian from Birmingham in the United Kingdom. Today I'm going to talk to you about the importance of diagnosing post-bariatric deficiencies early and how we can actually do that in practice. I am going to stick to the diagnosis side rather than the treatment time, but if anybody's got any questions afterwards, I'm happy to answer those. So what I'm going to cover today is I'm going to talk a little bit about how the micronutrient absorption can actually vary between different procedures. I'm going to give you a little bit of our data that we did here looking at zinc and selenium deficiency as well. And then I'm going to focus talking about how we actually screen for deficiencies. So the symptomology, what things we should be looking out for in our patients, but also the biochemical markers, so how we can actually diagnose those using blood tests. And then I'm really going to focus on the fact that prevention is much better than cure. We should be preventing these deficiencies from happening rather than from treating them when they do occur. So we have 4 different procedures that I'm going to focus on today. And if you can see across the screen here, the amount of malabsorption varies across procedures. So starting with the gastric band, actually there's no malabsorption occurring from this procedure. So it's what we call a restrictive procedure. The band is placed over the top of the stomach and there's no change to the anatomy there. When we move on to the sleeve gastrectomy, there is a small amount of malabsorption there you could consider because of the reduction in the stomach size, but anatomically in the intestines, we haven't altered those. Then moving on to the Roux-en-Y gastric bypass, there is an element of malabsorption there as we've bypassed a large proportion of the intestine there, and obviously the stomach size is reduced as well. And then we move on to the BPD, there's a greater element of malabsorption there that we will talk about in a minute. So what is quite important to think about, so we know actually what we're looking out for in terms of deficiencies, is looking at the sites of where different vitamins and minerals are absorbed in the digestive system. So when we look at the stomach, for the sleeve, the bypass and the BPD, an element of the stomach is reduced. So the only element we're really looking at there is copper, but as you'll see, copper is absorbed later on in the digestive system. So we don't worry too much about copper there. When we look at the duodenum, it's bypassed in the Roux-en-Y and the BPD, and the main elements to look out for there are things like your copper, your thiamine, your selenium, and your fat-soluble vitamins as well. When we move on to the jejunum, again, it's the Roux-en-Y and the BPD that affects that part of the intestine here. So the main elements to think about are your thiamine, your folate, your fat-soluble vitamins again, selenium, iron, and zinc. Now, the ileum is only actually affected with the BPD, so this is why it is considered the most malabsorptive of those 4 procedures. And again, there's the additional impact on the absorption of your folate, your B12, your vitamin D, vitamin K, and selenium. And we do not alter the colon in our bariatric procedures. So thinking first of all about the gastric band, and I think quite often the gastric band is actually often looked as a procedure to look at for deficiencies because we know that the anatomy isn't actually altered. So in terms of what we need to look out for, the gastric band does still cause an element of undernutrition. So patients feel much more satisfied of smaller portions of food. So actually the volume of food they're eating is smaller and therefore there is a greater risk of deficiencies there. Thiamine, we only really need to look out for in patients that really aren't tolerating that gastric band very well. So if there's prolonged periods of vomiting, or particularly in patients who may have fallen pregnant and are experiencing vomiting there, we do need to look out for a risk of thiamine deficiency. Vitamin D, I won't touch on too much here, but I'm sure Lillian is going to touch on this when she looks at the importance of preoperative nutritional screening. Patients with obesity are at greater risk of vitamin D deficiency, and we know that the weight loss achieved with gastric band isn't as significant as the other procedures, so the risk of vitamin D deficiency is still there. And although there's no malabsorption of the gastric band, we do often see iron and B12 deficiencies in our gastric band patients. And this is primarily due to the food intolerances that we see, particularly to meat, which makes getting those sources actually quite difficult. Moving on to the sleeve gastrectomy now. So again, there's the risk of undernutrition. So that's not only because the stomach size is reduced, which obviously induces satiety in that way, but there's also the hormonal influences as well. In terms of the vitamin B12, we know there's a reduction in the intrinsic factor because of the reduction in the stomach size. In terms of iron, it shouldn't actually lead to any malabsorption, but we know that there are intolerances to certain foods, as I said before, and also aversion. So because of some of the taste changes we see associated with the hormonal changes with the sleeve gastrectomy, foods that patients once quite enjoyed, they find quite unenjoyable now, and sometimes this can be food sources that are rich in iron. Have also said that actually when patients lose a significant amount of weight, the females may actually start having regular menstruation again, and that can have an impact on their iron levels there. Thinking about calcium, again, there's no malabsorption, but aversion, particularly to milk products, we find after a sleeve gastrectomy, particularly if they were on that pre-op diet for quite a while and following meal replacements. After surgery, they just do not enjoy milk anymore. And also we know that absorption of calcium is slightly impaired postmenopausal as well. Again, vitamin D associated with obesity that I'm sure Lillian will cover. And although I've put copper there, we don't often see a copper deficiency after a sleeve gastrectomy patient. So even though the stomach size is reduced, there is a proportion of the stomach there, and copper is absorbed later on in the digestive system. Moving on to the Ruon Y. So again, you've got the restrictive element there. Your stomach size is much smaller, but also we have those really profound hormonal changes, which means that patients just do not feel hungry anymore, and therefore their portion sizes are much smaller. It is actually got an element of malabsorption because we're bypassing that portion of the small intestine and the duodenum. So with the B12, there's much intrinsic factor than even with the sleeve gastrectomy, and also because of where B12 binds in the duodenum and that is now bypassed, that actually has an influence on the absorption of B12 as well. Iron absorption is reduced because of the proportion that we've bypassed. Again, there's some calcium malabsorption as well, vitamin D malabsorption, and there's an impact on your zinc, selenium and copper absorption as well. Lastly, touching on the BPD, this isn't a procedure that we actually do routinely in the UK at all anymore, but we do see patients as part of prolonged follow-up because we know of the risk of malabsorption. So we're still seeing patients 10 to 15 years after their BPD because they are still suffering with real chronic deficiencies. So with the malabsorption, it is much more malabsorptive. There's a reduction in the B12 absorption, the intrinsic factor and the binding. And again, as within the Ruon Y, your iron, your calcium, your vitamin D, zinc, selenium and copper are all reduced in terms of absorption. Quite uniquely with the BPD, because actually even a proportion of the ileum is bypassed, we also see malabsorption for some of the fat-soluble vitamins, so your A, E and K. So this is something extra that you really need to be vigilant of because there are some real side effects from deficiencies in those fat-soluble vitamins. I'm going to go through some of the symptoms of deficiencies. The main one to focus on is vitamin B12. So vitamin B12 can be really disastrous if it is not picked up early on. Things to look out for are quite often symptoms that you see associated with bariatric surgery. So quite often our patients will complain that they are tired, but these are symptoms much more beyond that. So heart palpitations, that classic smooth tongue that we often see. So often just asking the patients to stick out their tongue just so you can have a quick look to check that there's no signs of that there. It can impact in terms of digestion, but we know that procedures often can cause that anyway. Numbness, tingling, depression and memory loss are all symptoms there. Looking onto iron, again, fatigue. So this is a common symptom to be looking out in your patients. So patients are complaining and feeling tired. This is a sign of many deficiencies. Pale skin, headache, dizziness, cold hands and feet if they feel quite cold to touch. Again, looking at their tongue if it's inflamed, sore. Looking at their nails is always a really good sign to see if they're getting enough nutrition. So if they've got brittle nails, it means that they haven't quite got enough nutrition going on there. And also that very unusual cravings is a really distinct feature of iron deficiency. So sometimes patients say, I don't know why, I just really want ice, or I'm craving all these foods that I know I shouldn't be having. Looking at calcium, so calcium is really important for a lot of our muscles, so muscle aches, cramps and spasms, numbness and tingling. Having difficulty sleeping, again looking at the nails, alopecia and dry itchy skin. Vitamin D is a lot more difficult to identify, and as I'll talk a little bit later on, that's why we recommend routine screening, because there isn't an awful lot of symptoms associated apart from with that general feeling of feeling very tired, and people may experiencing that they're getting much more flu and colds than they used to before. Symptoms of zinc, so particularly in the early stages, it's so important because zinc is associated with poor wound healing. What's quite interesting is that zinc can actually have an impact on your smell and taste as well. So although we know there's some taste changes associated with sleeve and the bypass, as well it can impact their sense of smell. And they may be experiencing diarrhea, which also we want to be avoiding. Now I'm looking at selenium. So selenium is very important, particularly for patients who are looking to conceive or if they are already pregnant. It's got some real influences on the reproductive system there. It can also cause muscle weakness, fatigue, and hair loss. So this is the one that we see a lot. So patients coming to clinic and saying, so much of my hair is falling out, even though they're having enough protein in their diet and they're doing well in that area. But if there is a deficiency that does come up, we move them straight onto intramuscular. Thiamine, we supplement if there is prolonged vomiting, but really we should be investigating why these patients are vomiting. They shouldn't be having prolonged vomiting for significant periods of time, but you may see it in your patients in the early stages of pregnancy. So that's your 200 to 300 milligrams daily. And then we only specifically supplement above what is already in the multivitamin and mineral for the fat-soluble vitamins if there is the presence of steatorrhea, and we may prescribe it in our BPD patients if we have particular concerns as well. In terms of monitoring, so what I'll do is I'll talk you through our guidelines here in the UK. So for the gastric band, it's quite minimal monitoring that's recommended, so it's your U's and E's, your LFTs, and your full blood count. For your sleeve, your BPD, and your Roux-en-Y, it's monitoring every 3 months and early on, then 6 months, 12 months, and then yearly after that. And you can see on the screen that your trace minerals such as your zinc and copper are only actually tested at 12 months and annually. What I'll quickly just present on is some of our data from our centre, because we were actually quite concerned that trace mineral deficiencies are a lot more prolific than our guidelines had said. So we actually investigated this in our population. So this was some data presented at IFSO last year in Dubai. And what we found, so pre-op, which again I'm sure Lillian will touch on, there is deficiencies preoperatively in this group. So as you can see across the 3 procedures, there was a proportion of patients that had zinc and selenium deficiency already before we'd even done the operations. Afterwards, as you can see here, the prevalence of zinc and selenium deficiency for a Roux-en-Y does increase quite significantly. And for a sleeve, even though the British guidelines say we should only monitor zinc, actually selenium deficiencies were increasing at a higher rate. Gastric band patients did also experience an increase in these deficiencies as well, but not as to a greater extent. So just to sort of say, from what we found here, we did actually change our guidelines locally. So we may be considered to be a lot more cautious with our monitoring, but as I said, we want to prevent rather than treat these deficiencies. So with gastric band patients, we check their deficiencies obviously preoperatively, then at 12 months and annually. For our sleeves and bypasses and BPDs, we don't test copper unless we are specifically supplementing their zinc on top of what is available in their multivitamin and mineral because of the synergistic effects between zinc and copper there. So we'll only test that if we have been supplementing zinc. But we actually test for zinc and selenium as part of routine. We do this early on at 6 weeks to make sure that the deficiencies pre-op have actually started to be treated and they're on their way to being improved to normal levels. And then again at 6 months, 12 months, and annually as well. So some take-home messages really from me. So as we can see, deficiency risk will vary between procedures, and that's because of the impact on the absorption across the digestive system, and that varies between the different procedures. it's really, really important to be knowledgeable and to be aware of the symptoms of deficiencies, but do not rely on symptoms to make a diagnosis of a deficiency. Quite often these symptoms may never appear, or they may appear at a really, really late stage. So what I would recommend is locally you have a protocol for your screening for deficiencies from very early on post-op. And again, look at your national guidelines or the American or the UK guidelines, but see how that fits in with your centre. And that's where auditing is really important, to see in your local population, are those guidelines fit for practice? Check supplementation compliance. So although we're recommending this supplementation to prevent deficiencies, really compliance is a massive issue in these patients. So actually ask the direct question, are you taking every single multivitamin and mineral? And if they're not, you may need to do more regular testing. And as I said, the aim is to prevent deficiency rather than treat deficiency. So be really vigilant and have your protocols in place from really early on post-op. That's everything from me. Thank you very much.
Thank you very much, and sorry for the interruption. We got through the entire presentation very nicely, and thank you for waking up early and joining us at this meeting.
That's okay.
And with that, we move on to our next speaker. Thank you, Sally.
No problem.
Bye. Yeah, hello, one more thing, sorry. The mic is not that sensitive, so you could not hear the round of applause from the audience. Everybody appreciated your talk a lot. Thank you.
Oh, thank you.
Bye.